Now let me introduce Professor John Sanderson, who is actually a very known heart failure expert. He's special to me because he's my mentor. He's from UK, but he actually worked at Chinese University of Hong Kong for many years before he moved back to UK. And then now he's still coming to and fro and also be our honorary professor. Now, John is a very eminent man, a professor in the field of echo and heart failure. So today he will be talking about the management of heart failure with preserved EF and the role of home monitoring. So Professor Sanderson, please.
Thank you very much, CM, and thank you very much, Professor Chasm, for inviting me here again. I enjoyed my time very much last time, in the last meetings, and I'm glad to be back. I just want to, a lot of questions about this very interesting condition, and home monitoring was part of my title, but I'm just going to put that at the end because actually that's probably the less interesting bit. I'd like to start with just a quick word about what we call this condition. And I just wrote this viewpoint recently because I was concerned by this word preserved, which is actually quite misleading because we know that the definition of the word preserved in English is to maintain something in its original or existing state. And one thing which is not preserved is the ejection fraction in patients with heart failure and preserved ejection fraction. Because we've just seen this slide before, it shows quite clearly the ejection fraction falls in patients with this condition. Now, I was on the committee of the European Heart Society working group for making the guidelines for what we called HFNEF, heart failure with normal ejection fraction. And that was opposite to heart failure with reduced ejection fraction. Now, somewhere, I think from the Mayo Clinic, they came out with this idea of using the word preserved because they said normal was difficult to define. Although, interestingly, they have no problem defining reduced. And they also introduced a small p, which I don't know why they have a small p. But I would just like to make a plea that we should really use the word HFNEF, which is actually the most honest term to describe this condition. But I think I've lost that battle because the North Americans are using HFpEF. But we must remember what George Orwell said, that politics or thought can corrupt language, and language can corrupt thoughts. If you label the condition diastolic heart failure, you will think the problem lies entirely in diastole. Okay? If you label it preserved ejection fraction, you will forget that the ejection fraction will fall. And actually, 39% of people with so-called HFpEF in this study had an ejection fraction of less than 50% at some point after the diagnosis. Okay? So a lot of these patients progress. And actually, this is rather comforting to me because I produced this graph many years ago where I tried to separate what is the difference between HFnEF and HFrEF. And most patients with heart failure with reduced ejection fraction have ischemic heart disease, as we know. They have an acute MI. They pass through a phase of actually what we would call diastolic heart failure because they've got a low SM, reduced longitudinal function, but with a normal ejection fraction. So eventually they get down to here and they have systolic heart failure. People with hypertension and diabetes has much slower progress. So for a long time, they have a normal ejection fraction, but they will have reduced longitudinal function. And normal aging is a declining longitudinal function. And we know now that this question mark can be removed because there's good data showing that these patients progress. So the difference then between these two conditions is largely due to remodeling. Okay, that the patient with hypertension and diabetes will progress eventually to reduce ejection fraction, particularly in areas like Asia and Africa where the treatment of hypertension is not good. So the reason that the treatments that work in systolic heart failure are basically anti-remodeling treatment, whereas in HFnEF, the heart has not yet remodeled or increased the volume. So there may be one reason, which we'll come back to, why the treatments works in systolic heart failure, but not HFnEF. But the big difference is the change in volume. And that's why these anti-remodeling drugs work so well in systolic heart failure. And we know that all these drugs work, and we've made great progress over the years, reducing the mortality in patients with systolic heart failure. But now, as we know, as I said, the main difference between these conditions is actually volume. And personally, I would like to reclassify heart failure into those with big hearts and those with small hearts, which is much, and get rid of the word of ejection fraction, because it's very confusing. So the problem about, as we heard earlier today, about treatment of HFnEF, there have been a lot of trials done which have tried various drugs, ACIs, etc., and beta blockers, and as you can see on the right here, they've all been neutral, no success at all. So that's a very interesting question. It tells us something about what's going on. I'll come back to the TOPCAT trial, which I think is probably being misinterpreted. So there's no conclusive evidence effect for any standard therapy on mortality. Diuretics certainly work, and I'll show you some data about symptoms on that in a minute. ACI and ARBs, I think, should be used if they've got hypertension, which most patients have, and they may prevent regression. And beta blockers may also be helpful for people with atrial fibrillation and tachycardia. So here's the trials, which you've seen already, so I won't waste much time on that, not much difference, but as I said, I'll come back to TOPCAT later. But what did show is in the use of BNP, which what Professor Michael Hennion was talking about, that BNP may well be a very good marker for people who may well respond to treatment, because we know that these people have probably definite heart failure. Now, just a quick word about diuretics. This slide actually is on quality of life using the Minnesota, which has been well documented. We did this in Hong Kong, and you can see that diuretics actually did reduce the symptoms quite significantly, quite quickly, by 12 weeks. Adding irbesartan or adding ramipril actually made very little difference. So actually diuretics do work in reducing the symptoms of this condition. So I think a lot of this is already being talked about, and I don't want to waste any time. But the reason is, why is the poor results to all this treatment? Well, I'd like to remind you a little bit about heart function. William Harvey knew this well in the 1750s, that the heart twists. And I think we forget this, because when we look at a heart like on an echo or an MRI, you have no idea that the heart is twisting, okay? And the heart twists during systole, like that, and it untwists and springs back during diastole. And during that process, it sucks the blood. And the heart is a suction pump. And the most important thing for early diastolic filling is suction, okay? And that's what is the problem. But it's very complicated. Now, when the heart contracts, the heart is built. God, or whoever made our hearts, designed it very cleverly. The fibers are wrapped around the aortic ring, the mitral and tricuspid ring. And this ring comes down in systole and goes up in diastole. Now, you can imagine, if you're a particle of blood, a molecule, a corpuscle sitting in here in the left atrium, at the beginning of diastole, this will rise up around the blood. So one of the reasons that blood goes into the ventricle is actually the ventricle moves around the blood. So that's a very important concept. If you lose that up and down motion, you lose a lot of your left ventricular function. And MRI studies have shown this longitudinal function constitutes about 60% of the function of the heart, of the contribution to stroke volume. So this motion, twisting, pulling down the ring and letting it go during diastole, is very fundamental to cardiac function. And we've forgotten about it for about 300 years. But now we're beginning to get some techniques where we can study this. As CMU pointed out, actually in Hong Kong, we were the first group to measure this movement and show it was reduced in patients with HFnEF. It's clearly they have reduced longitudinal function, and lots of studies now have shown, not only using TDI, but strain rate, and the latest thing is global longitudinal strain, which has been confirmed to be reduced in nearly in the majority of patients with HFnEF. So there is systolic dysfunction. Because the ring doesn't move down, it doesn't move back, and that is very important. This is a study, after I left Hong Kong, I went back to England, and we did this study in Birmingham, where we used some of these new techniques. And I won't, to cut a long story short, we found There was a as some of this CMU showed that some of this data, the reduced ability to increase longitudinal functional exercise. There's reduced rotation and delayed untwisting. This reduced ventricular suction, and this correlated with the VO2 max. And this is a kind of summary, right? So you start off with reduced systolic function, partly, okay, reduced long axis function, reduced rotation, delayed untwisting, and perhaps there's some degree of actual delayed relaxation, reduced ventricular suction, so you have less early diastolic filling. You have to have increased late diastolic filling. Why do you have the ARP pattern on the echo? You have a reduced E wave and a big A wave, because the A wave has to compensate for that loss of early diastolic filling. This leads to an increase of end diastolic pressure, particularly on exercise, which, as we heard earlier, is when people get breathless. So the pressure rises on exercise and they begin to feel breathless. So this, I think, is part of the problem. It's not the whole problem, but it's part of the problem of this condition. Now, we heard about dyssynchrony, and indeed there is, you can measure dyssynchrony in different ways, but one way we looked at it is to look at what we call torsional dyssynchrony, because there's a problem with untwisting. So there's a loss of relationship between longitudinal and radial function. In the normal heart, it's beautifully controlled. The heart relaxes in a longitudinal fashion and a radial fashion at the same time. But what we found in patients with HFnEF is it's totally disorganized, so that there's a huge difference. This is the normal heart. It goes up and down normally. There's very little disturbance between the twists and the longitudinal displacement. In patients with HFnEF, there's marked disturbance, and you can see that the thing becomes disorganized, okay? And this disorganized function of systole and diastole, where things move at the wrong time, the longitudinal function's delayed, and it has a huge impact particularly on ventricular suction. So the conclusion of our study, this is not a problem of isolated diastolic dysfunction, and there are people still who call this diastolic heart failure. Okay, I think this is just ignorance, really. And it's not a problem of ventricular stiffness alone. There are many, and when you start thinking about it, you start thinking, well, designing a drug which is going to relax the myocyte better is clearly not going to answer the whole problem. There are a whole lot of other things which affect the way the heart can relax and the movement of the ring up and down, including particularly fibrosis, which I'll come back to. So one other thing which is forgotten about, this late diastolic filling means you have to have good atrial function. But the problem is, on exercise, and as you get older, your atrial function begins to decline. And we found on exercise that if you measured atrial function, the normal increase in atrial function does not occur in these patients. So they start getting atrial failure. Actually, this condition is predominantly a condition of atrial failure. The atrial systolic function declines eventually because atrial failure begins. And finally, they get atrial fibrillation. And one of the commonest causes of hospital admissions in these patients is atrial fibrillation, which is a form of atrial failure. So atrial function is very important. And if you want to improve the symptoms in these patients, it would be nice if we had a drug that actually improved atrial function. And particularly, you must try and prevent the development of atrial fibrillation. So I won't, because of the presence of time, I won't go through a lot of this. Now, I want to just spend a bit about hypertension, because we know, as I said earlier, coronary artery disease is the major cause. If you look here, it's a predominant cause in patients with reduced ejection fraction. Hypertension is largely the production cause. Myocardial infarction was quite common in people. So hypertension is fundamental to these patients as they get older, combined with diabetes and aging. And we know that hypertension, for a long time we've known, is not just hypertrophy of the myocardium. The whole of the myocardium is disorganized, with loss of contractile elements, disruption and deposition of fibrous tissue. And that affects not only the diastolic function, but it affects the systolic function as well. This movement of the ring goes down. Now, spironolactone, let's come back to treatment, is very interesting because a lot of work, a very good person called Carl Weber did a lot of very interesting work, and this Briller did some work as well, giving this spironolactone to rats with myocardial failure. And spironolactone has a very powerful anti-fibrotic action. and it prevents and will reduce fibrosis. So you would think it would be quite a useful drug. And also in patients, this study by Mottram and and they found evidence there was improvement in left ventricular long-axis function after giving spironolactone. We also found it in a study we did in reduced heart failure patients some time ago, where we gave patients spironolactone, doing an MRI study, which is published in JACC, and we showed that spironolactone had quite a marked effect on the end systolic volume, suggesting changes in shape change and reduction in fibrosis. So why did TOPCAT fail? It was very disappointing. I personally thought that aldosterone antagonist spironolactone would be useful in this condition if they had an anti-fibrotic action, which may help the fibrotic tissue. Well, it turns out that the overall results were fairly neutral. But there's just been, as I mentioned earlier, a very interesting analysis, pre-specified subgroup analysis, looking at patients from North America and those who were largely enrolled from Russia and Georgia. The reason for this is their criteria was previous hospitalization for heart failure, but they didn't have the benefit of NT pre-BNP measurements. And when you look at this analysis afterwards, you can see the primary outcome is significant in those patients who were recruited using BNP, and you can see here the much higher mortality, much higher outcome measurements, events in this group who had high BNPs compared to CV death here as well, and also heart failure hospitalization. These are all significant. More interestingly, when you look at the things like systolic blood pressure, you can see that there's a huge effect of spironolactone on blood pressure. Very little effect in this group of patients. Okay? The same again, potassium goes up as expected. No rise, very little rise in potassium in this other group of patients. So the question is, and here again in creatinine levels, no rise in creatinine, which you would expect with spironolactone. So the question is, did these patients have heart failure? So of course, if you give spironolactone to people that don't have heart failure, you're not going to expect much benefit. And I think this is, unfortunately, blurred the results of this result. And I think probably spironolactone will be beneficial in these patients. And I don't know what's going to happen now, where they're going to have to repeat this study, doing it again, using correct, using BNP as a criteria. Anyway, pathological LVH is associated with both diastolic and systolic abnormalities. I haven't shown you. We did some work years ago showing that people with LVH have reduced long-axis systolic function as well as diastolic. And the seeds of the progression are present within the hypertrophic ventricle. And this fibrosis can lead to remodeling and probably accounts for those patients who move from the HFNEF group into the HF reduced ejection fraction. And I can say, if you work in Africa, and I know some people, I worked in Nigeria and also Kenya for a few, doing research sometimes in my life, and you saw many patients presented with classical systolic heart failure who had no risk factor other than hypertension. So presumably they moved from a HFnEF to a reduced ejection fraction pathway. So the treatment of HFnEF should be aimed at preventing that. And I think that this has not really been studied properly, yes, in looking at follow-up ejection fraction measurements in people given ACIs or ARBs to see if you can prevent that progression from HFnEF to HFrEF. Here's something which may be the future, perhaps. This is a growth differentiating factor that reverses age-related cardiac hypertrophy, which sounds wonderful because we know that aging affects our faces, unfortunately, and when you get to my age, you start noticing it more, and not much you can do about it, really. But it also affects our hearts, because our hearts, as we get older, they begin to lose that suction. And actually, one way to try and prevent or slow that is to take regular exercise, and it keeps your ventricular suction better. But undoubtedly, there are changes going on in collagen and things within the heart that makes you lose that ventricular suction, which is why you can't run quite so fast on the treadmill at 65 when you're compared to 35. Now, there's a huge business out there. As we know, billions are spent on anti-aging products to try and make us look younger. But what we need is an anti-aging product for the heart. And that may well be beneficial to patients with HFnEF. So I wrote a little thing in Michael Henion's new journal, which I think just summarizes what I want to say, that HFnEF is likely to be a multifactorial condition, several causes and complex abnormalities of ventricular mechanics, affecting both systole and diastole, probably mainly due to changes in ventricular matrix or fibrosis, coupled with atrial dysfunction, vascular stiffening, including the venous system. The venous system is very important, changes in capacitance. Vascular stiffening, including the venous system, autonomic dysfunction, the chronotropic incompetence, blood pressure, and venous tone. Expecting a drug, a lucitropic drug, or any single medication to cure all these things is fanciful, and I think you were saying the same thing earlier. This is the new journal that Professor Henion's editor of. Finally, 2 minutes on home monitoring. I think this is quite quick. Patients can be taught to monitor their weight and etc. And we know the reason for doing this is to try and prevent hospital readmissions, because at least 25% of patients are readmitted within 30 days, and by 6 months it's 50%. So we could reduce readmissions, we reduce our hospital expenses a lot. So there's been a lot of interest in trying to do this, and there are various formats. One is the structured telephone support, which is basically ringing up the patient regularly, once a week, asking them how they are. They measure their weight every day. You get the weight, and or maybe sometimes they can measure their blood pressure as well, and you can give them some advice. You know, if they're getting more breathless, maybe they could take some more diuretics. The other more technological way is to use various devices or transmitters to transmit the data directly back to the hospital from the patient. And this can be invasive or non-invasive techniques as well, measuring simple things like blood pressure, etc. The invasive ones are implantable pressure sensors, measure right atrial pressure, pulmonary artery pressure, or even now left atrial pressure, and also impedance attached to computers, attached to devices such as CRT devices. Well, if you look at all the recent results, there's been some positive results. Some of them have shown reduced hospitalization. A lot of them are not significant, but there's been fewer emergency heart failure in this home HF study, etc. But some have not been very significant at the moment. This is just an example, and I'm actually quite interested in this, because if you look, this is patients with diastolic heart failure and patients with systolic heart failure. This is looking at the RV diastolic pressure, which is kind of related to left atrial, to pulmonary artery diastolic pressure, and therefore left atrial pressure. And you can see that people with diastolic heart HFnEF, Professor Zeil is somebody who insists on using the term diastolic heart failure the whole time. He doesn't believe there's any systolic problem at all. But you can see here how these patients' pressure rises very rapidly, very quickly. And because of, I think, a problem in venous compliance. I think their veins tighten, so the pressure rises very quickly. And also their atrium and their ventricles are stiff, as we heard earlier. And if you can detect this pressure rise, you can probably get in here and maybe ask the patient to increase the diuretic, if they know what tablet they're taking. I think many old people have 12 tablets. They're not sure which is a diuretic. So you have to explain that to them. Interestingly, the body weight didn't change very much in these patients. So body weight is not always a good way to measure, to detect the changes which are going to come. And there are a lot of unresolved issues about these techniques though. Simply monitoring the patient is not enough. You have to do some action. And is it just up titrating the drugs? What patients are likely to benefit? If the patient's well controlled, they're not likely to benefit. What you need to target is the unstable patients, the patients at high risk who are more likely to be readmitted. What data to monitor? You're measuring pressures, are you going to measure impedance? Actually, it turns out the more things you can measure, the better. And there are new algorithms available which measure multiple factors which may be much more predictive. Who receives the data? It all goes into a hospital data bank. Somebody has to analyze it. Somebody has to respond to it. Somebody has to ring the patient back and tell them what to do. That requires a lot of organization, so it doesn't always save a lot of money. And there will be a huge volume of data to handle. Again, somebody in the department has to have the responsibility for that. So there are a lot of resolved issues. So it sounds attractive to hospital administrators to reduce hospital readmissions, but actually the costs sometimes sometimes, will be not, there's cost savings. We're not so big as it is. So I'm sorry I overran a bit. But as we know, this is a very interesting topic and a lot to discuss. I want to say some important thank yous to my team when I was in Birmingham, but much more important, I spent more time in Hong Kong, where I'm back there again now, to press the CMU. We've worked together for a long time, maybe more than 15 years. And Gabriel Yip, who was a great colleague, and all my other colleagues there, and who we worked with over many years.